All right. Well, thank you very much. Thanks, David, for that very kind introduction. And it's really an honor and a privilege to be here today to speak with you all on such an exciting topic. David really set the stage nicely. We are in a situation now where we have an embarrassment of riches, really, with respect to AML. After many, many years of struggling with therapies that have not moved the needle, we now have a huge number to use and to evaluate. And so I'd like to fairly quickly go through these options, these new therapies, how they work when we think about using them, and I hope this can be helpful. So let's flash back all the way to a completely different era in AML, March of 2017. So if we just go right before that prehistoric era, we had a very binary approach to the treatment of this disease. Essentially, when a patient had newly diagnosed acute myeloid leukemia, there was one question that was important to ask and answer. And that was, is the patient a candidate for induction chemotherapy, the 7+3 regimen? Because if they were, then certainly that was the thing to do. But the reason this decision was so crucial and important is that answering no to that question cast the patient into a very difficult situation where not only was there no FDA-approved therapy for most of these patients, but there was, in a lot of cases, no realistic hope that a patient could do well if you answered no to that question. So we are now in an era where things have certainly changed. But what's interesting, and we can talk about this a little bit more later, is that the sort of weight and importance of this question hasn't really gone away. And for a lot of, in a lot of ways, you can understand why, because for decades, this question was essentially asking whether a patient had any chance of living or dying. But now, in the new era that we're in, I think we really need to reevaluate the importance of the question of whether a patient could be a candidate for intensive chemotherapy, because in the presence of options, I think the question takes on some very different implications. So, as I suggested, March of 2017 hit, and there has been big changes in our field. And if it looks like we're running out of room on the right end of the slide, that's actually appropriate because it gives you a little bit of context as to the desert that we were operating under for many, many years since the first since the first paper that showed the efficacy of 7+3. So besides some sort of on and off again relationship with Jimtozumab, starting in 2017, as David suggested, we've had 8 approved therapies, and we think probably more to come in the near future. So how do we sort of think about these, and how are we going to talk about them this afternoon? I like to think of them in 2 broad categories. So we can think of genomically targeted personalized therapies, and then we can think about non-genomically targeted therapies. And so I think there's different implications for both of these, which we'll get to. But when we talk about personalized, genomically defined personalized therapies, we'll talk about FLT3 and IDH, and then we'll talk about a variety of other non-genomically targeted therapies in that section. So let's start with the first category, the genomically targeted personalized therapies. And just for context, I think this is a fascinating way that we arrived at this moment. It's been almost 10 years since the first patient with cancer had whole genome sequencing performed, and that patient happened to be a patient with acute myeloid leukemia. And since then, there have been other papers published of multiple patients who have had whole genome or whole exome sequencing. And as a result of all of this, we now have panels of targeted resequencing that we most of us typically do as standard of care at the time of diagnosis for an AML patient. So there's this wealth of information, genomic information, that we get as standard of care every time we start to treat a patient. So you can understand why it has become so logical that we pay so much attention to this information, and many people think that the solution to this problem of AML is going to be A, understanding the genomic landscape of each patient, and then B, targeting the different mutations that each patient has. And so we'll start by talking about FLT3. Our knowledge of FLT3 goes back many years before the era of whole genome sequencing and next-gen sequencing. We've known that FLT3 is a common mutation in AML for many, many years, and we know that it afflicts about a third of patients who have normal cytogenetics. And we also know that when this mutation occurs, patients do worse. These are the patients that typically have very proliferative disease. Interestingly, the bad outcomes from FLT3 positive patients are not necessarily due to refractory disease. So these patients with induction chemotherapy don't have typically a harder time getting into a remission compared to FLT3 wild type patients. The reason these patients do poorly is typically relapse, and that is what limits them. So Midas Turin is a multi-kinase inhibitor. It also, among a laundry list of targets of kinases that it inhibits, includes FLT3 ITD and TKD. And in a randomized study of younger, newly diagnosed AML patients who were fit for induction chemotherapy with 7+3, they were randomized to receive 7+3 plus a placebo versus 7+3 plus midostaurin. And the midostaurin was given days 8 through 21 of induction, as well as some consolidation, and there was a maintenance phase of the study as well. And this is the study that ushered in the new era that we're in now with its approval in March of 2017. And this is sort of the bottom line data of what was called the RATIFY study. As you can see, a significant overall survival benefit between the two arms, the midostaurin versus the placebo arm. And you can see that there was a 23% reduced risk of death in patients who received the midostaurin. Interestingly, patients so this was a long study, took a long time to accrue, and it kind of crossed a couple different treatment eras. And by the time the study was maturing, it was becoming much more common for patients with a FLT3 mutation to go to a transplant. And so there was some censoring that needed to happen to account for that. And many of us who think of transplant as the great equalizer, it doesn't matter what your disease biology is. If you get in remission and go to a transplant, it should sort of level the playing field. What was very interesting to find is that that was not true, that patients with a FLT3 who got midostaurin and went to a transplant compared to patients with a FLT3 who did not get midostaurin and went to a transplant, there were differences in those outcomes. So I think the important message is it is really crucial to understand a patient's disease biology at diagnosis, because the things you do or don't do can affect outcomes even in the setting of a transplant. Okay, so moving on to another FLT3 inhibitor, this is gilteritinib. Gilteritinib is sort of a next-generation FLT3 inhibitor. It's highly specific for FLT3 compared to midostaurin, which, as I said, affects a lot of other kinases as well. And in the ADMIRAL trial, which interestingly we haven't officially heard about, but you can read about on the package insert from the FDA approval of this therapy, in 138 relapsed FLT3 patients with a median age of 60, there was a response rate, a CR or CRh rate of about 21%, median duration of remission of about 4.6 months. And as I said, this data led to the recent approval of gilteritinib for FLT3 positive relapsed AML patients. Okay, so moving on to another gene target, isocitrate dehydrogenase has been a fascinating story. So back to that first patient who had whole genome sequencing with AML, turned out that patient had a mutation in this gene called IDH1. And that was very surprising because although IDH was known to be a gene that was mutated in other types of cancer, it had, at the time was not understood to be recurrently mutated in patients with AML. But after the identification of this one patient with an IDH mutation, it was noted that about 15 to 20% of AML patients actually have mutations in IDH1 or the isoform of IDH1, IDH2. And so IDH is a gene that's involved in metabolism, in the Krebs cycle. If you remember back to your biochemistry days, IDH is responsible for the conversion of isocitrate to alpha-ketoglutarate. And this is just one of the many steps, if you remember back in the Krebs cycle, that a cell would use to generate energy. In the presence of a mutation in IDH1 or IDH2, which is in the mitochondria, IDH1 is in the cytoplasm, you overproduce a chemically very structurally similar enzyme to alpha-ketoglutarate called 2-hydroxyglutarate. And you overproduce it in such incredibly high levels that you just outcompete all of the enzymes in the body that are dependent on alpha-ketoglutarate with this similar compound called 2-hydroxyglutarate. And that has a variety of effects on disabling certain enzymes in the body and in cells that prevents the proper maturation of a cell and can lead to leukemogenesis or the development of AML. It is thought that this is it was thought from early on that this would be a druggable mutation and that there would be the potential that this could trigger differentiation. And in fact, when you look at enasidenib, which targets IDH2, and ivosidenib, which targets IDH1, both of these drugs are now FDA approved for the appropriate situation, IDH2 or IDH1 respectively, relapsed AML for use with a single therapy, this orally available therapy. And you can see the response rates in the 30% range with overall survival about 9 months. So that's sort of the expectation for this therapy. One needs to consider this special toxicity that can occur, or toxicities that can occur. I alluded to this before, but differentiation syndrome can be triggered when you target IDH, and that's something that happens relatively rarely, but needs a lot of special attention and therapeutic intervention. Leukocytosis, related or unrelated to the differentiation syndrome, can occur. Enasidenib causes an indirect hyperbilirubinemia, which is of no clinical consequence, really can be ignored. And there's some QT prolongation in ivosidenib that we don't see in enasidenib. Okay, let's move on to the non-genomically targeted therapies. So CPX351 or liposomal cytarabine daunorubicin, this is 7+3 packaged up in a fixed 5-to-1 molar ratio of the cytarabine and daunorubicin. And the thinking is that perhaps this will have less toxicity, more bioavailability, more concentration in the bone marrow. And in an initial randomized study, overall with older patients that received 7+3 plus the CPX351. It was a negative study, but there was an unplanned cohort of patients that had secondary AML, so as defined as AML from an antecedent hematologic condition or a treatment-related AML, and they did have a survival benefit. So the investigators in the company, they did another prospective clinical trial just focusing on this population of patients, and they once again found in this study that was designed to answer this question specifically, a real clinical benefit. So there was an improvement in response rates, as shown on the left, with respect to CR and also looking at CR plus CRI, as well as overall survival when you look at the CPX351 versus standard 7+3. And what I'm not showing you is that toxicity was a little bit better in the CPX351 arms as well, with a lower early death rate compared to 7+3. Jimtozumab ozogamicin is an antibody drug conjugate. It takes advantage of CD33, which is expressed on many, if not most, AML blasts. And it targets CD33 and is linked to this poison called calicheamycin. So, and calicheamycin is a very toxic compound, but when introduced specifically into the target cells of interest, you can have some selective therapeutic death. And so that's essentially what Jimtozumab is designed to do. If you remember back to that timeline, Jimtozumab has had this interesting history of being an approved drug and then withdrawn and now reapproved. And this is a meta-analysis I'm showing you of several different studies in AML that use Jimtozumab. Now, those of you who look at the AML literature, you know there are not many meta-analyses in, essentially a rare disease. And so this is pretty powerful, especially when you look at the patients who are better able to respond. So you can see that there's one side of this plot that favors more Jimtozumab, the other, and the closer you get to the line in the middle, the sort of less distinct the differences are. And you can see a pretty prominent improvement in outcomes, specifically in patients who have good risk cytogenetics. And so, although the FDA label states that Jimtozumab could be appropriate for any CD33 positive AML patient, relapsed, upfront, single agent, or with other therapies, most of us are now sort of thinking about using this more with the good risk patients at the time of diagnosis in combination with 7+3. Glastigib is a small molecule inhibitor that inhibits something called smoothened, which is in the hedgehog signaling pathway. Hedgehog signaling pathway is a pathway that cells mostly use during just fetal development to make limbs and fingers and things like that. And then after birth, this pathway in most cells is deactivated. But cancer cells can hijack this pathway and use it to overexpress it to lead to their cell growth inappropriately. And so the thinking is that if you can target that, you can specifically target some of the cancer cells. And specifically, there's some literature about how this may be more prevalent in the leukemia stem cell population. So in a randomized phase 2 study of untreated, unfit, older AML patients to receive either low-dose cytarabine alone or low-dose cytarabine plus Glastigib, there was an improvement in overall survival. So response rates are shown on the right, and you can see that in the this is a small study, and in the low-dose cytarabine arm, there was probably fewer responses than we would expect in a normal control arm. But this was a randomized controlled study, and there was an improvement in response rate and an improvement in overall survival, as you can see as well. Now, some may question whether the clinical significance of the amount of time that this afforded patients is of value, but certainly the study was powered to look at statistical significance with respect to survival. It was significant, and it's now an approved therapy. And then finally, I want to spend some time talking about venetoclax. So venetoclax, I think most of us agree, has really revolutionized the treatment of this disease. And David alluded to this a bit. I think on our inpatient service, this has really eroded significantly into the patients who are getting traditional chemotherapy. Venetoclax is a highly specific inhibitor of BCL2. And we've shown some recent data that this can really effectively target the leukemia stem cell population. And in early phase clinical trials, uncontrolled, we have shown that venetoclax with a chemotherapy backbone, either a hypomethylator or low-dose cytarabine, can result in really fairly dramatic response rates and durability of responses and survival. Now, these, as opposed to most of the other studies I've shown you this afternoon, this is not a controlled study. That study has been fully accrued, and we await those outcomes. But this is the data we have so far. So when we just focus on the venetoclax plus the hypomethylating agents, either azacitidine or decitabine, you can see CR plus CRI rates in the neighborhood of 70%. Now, when I see a patient or saw patients before the venetoclax era who weren't fit for chemotherapy and we talked about a hypomethylator alone, usually my conversation was somewhere around a 30% response rate was the expectation. So again, not a controlled study here, and we await those results, but certainly better than what we would expect from the controlled population. And what's also really exciting is when you look across different biological subgroups that are traditional adverse risk bad cytogenetics, patients with secondary AML, patients with particular mutations like P53 and FLT3, there doesn't seem to be the decreased response rates that you would expect to see in an era of chemotherapy with these venetoclax-based strategies. So again, small numbers, uncontrolled, but very exciting that perhaps the mechanism through which this works is sort of agnostic to the bad biology that we know and fear in the context of chemotherapy. This slide just shows what I alluded to before, that really response duration and overall survival, again, a little hard to put this in context without a control arm, but certainly better than what we might expect, at least looking at the azacitidine patients, median of about a 22-month remission duration. And in some cases, when you take out the non-responders and just look at the survival of the patients who responded, which is the majority of the patients, because most patients did have a response, we're seeing things like, not having yet reached the median overall survival with fairly long follow-up in some subsets, particularly the azacitidine subset of the venetoclax patient study. So I think lots and lots of reasons to be optimistic. That was sort of a quick tour de force of the new landscape of AML. But hopefully that's helpful, and I know we all look forward to the very near future where we're going to learn how to use these even better and also have even better therapies to add into the mix. So thanks so much for your attention.